So excited to be interviewing Dr. David Light today. This is a huge part of my why learn, look, locate. Understanding your reconstruction options is so very important if you are facing a lumpectomy, a single mastectomy, and double mastectomy. And Dr. Light has been so kind to dedicate his time, his expertise, and his compassion towards this incredible global movement and women all over the world to help them understand the amazing advances that are going on in the world of breast reconstruction. So I am so honored to have you today, Dr. Light. Thank
Thank
you.
you. Good to be here.
I'd love to know why you want to be part of Learn, Look, Locate.
Well, I think our missions are aligned. I think that your mission to create a global movement of education for women when it comes to breast cancer is the same thing that where my interests lie. A very large portion of my practice is breast reconstruction, and the education process is critical, making sure patients understand what their options are, and laying out the risks and benefits and allowing them to make an educated decision is very important. And that goes for not only the patients who are walking into my office, but also the folks that are out there that may not be in New York where I'm located. I'm happy to share this information so that they're fully aware of what their options are and that they're making educated decisions as well.
Yeah, and as a breast cancer survivor of 5 years who was not offered any of the options that are, I cannot believe the incredible advances that are out there. I'd like to talk about that. And today we're going to be talking about many different topics so that anyone who's really exploring all their options is fully aware that there are plastic surgeons that are highly skilled and trained in some of these unique options. And so we're going to take a deep dive into, let's start with the tug flap. What is a tug flap?
A tug flap is a thigh-based free flap. The two most common flaps that come from the thigh are the PAP flap or profunda artery perforator flap and the tug flap, which is the transverse upper gracilis flap. So both of them originate from the inside of the thigh, and it's the same concept as a DIEP flap or a lumbar artery perforator flap or any of the other flaps that come from different areas on the body. We're taking tissue along with its blood supply, transferring that tissue up to the breast, suturing the artery from the flap to an artery in the chest, vein from the flap to a vein in the chest, and reestablishing blood supply to the tissue so that it survives and ultimately becomes a soft, warm, natural breast reconstruction for the patient.
Wow, like this was never offered to me, okay? I never knew what this was. And how long is that procedure? Is it a difficult procedure? Like,
It depends if we're doing one side or both sides.
okay.
All microsurgical procedures are a little bit challenging. They're tedious. I think they're best handled. It's something that you don't want to dabble in. There are plenty of microsurgeons out there that do these procedures regularly. They do them with an extremely high success rate. Success rates greater than 99%. And those are the folks that you want to have operating on you. And when you do a lot, you become more efficient. And so they do take a number of hours, but patients do very well. They recover quickly. They're back on their feet. They're ambulating, walking the next day, and it's usually a 1 or 2 day stay in the hospital. So very big difference the way these flaps were treated years ago. We've come a long way on a number of different fronts: pain medication, efficiency in the OR. And so patients are just doing remarkably well and getting back to their normal lives a lot faster than what they were, even 10 or 15 years ago.
So before someone decides they're going to get, reconstruction and think saline silicone, there are so many other options where we're using natural tissue from our body, which I just think is amazing. And let's pivot to, there's another one. There's one called the gluteal free flap, the gap flap. Can you tell us about that?
Yep, another free flap comes from the gluteal region. There's a superior gluteal artery perforator flap or an S-gap flap, and then there's also an inferior. And it's basically, taken from the buttocks flap. There's a vessel that supplies the blood supply and the perfusion to the tissue, and that is dissected free and transferred to the breast, just like a DIEP flap or a TUG flap or a PAP flap. Same concept. Basically, it's just where we're taking the tissue from and which blood supply is supplying that portion of the tissue.
So we have tug flap, we have gap flap, and we have tram flap. What is a tram flap?
Tram flap is sort of the predecessor to a DIEP flap. The difference between a tram flap and a DIEP flap is with a tram flap, the rectus muscle, that's tram, the R in tram stands for rectus muscle. The rectus muscle is taken along with the skin and the fat. I haven't performed a tram flap since I was a resident, and it was only one or two while I was a resident. The tram flaps harvest the muscle, which weakens the abdomen. And so with the DIEP flap, we're preserving the muscle. We're not taking the muscle at all. We're just moving the skin and the fat up to the breast for the reconstruction. And it's a procedure that does not weaken the abdominal wall. It allows patients to go back and to their normal activities prior to surgery. And it's definitely the evolution of abdominal-based free flaps. So tram flaps, they're still being performed, but my preference is always a DIEP flap for patients, just because the morbidity is lower, the complications are lower, and the patient's abdominal wall strength is 100% afterwards.
On the DIEP flap.
On the DIEP flap, correct.
Okay. Okay. Wow. So there is a difference, but they're both coming from the abdomen, correct?
Correct. Yep, exactly.
So interesting. What about the latissimus dorsi flap? That's a
So
mouthful.
the latissimus flap in breast reconstruction is usually a pedicle flap. So that's moving skin and fat and the latissimus muscle from the back. But unlike all of the other flaps we just discussed, we don't disconnect the latissimus flap from the body. The muscle is actually swung from the back around to the front. The blood supply stays attached, and it's called a pedicle flap. Whereas a DIEP flap or a TUG flap or a gap flap, we disconnect it from the body and then reattach it by suturing the blood vessels together. And so the latissimus flap used to be a very common flap that was performed, especially in women who had had radiation to the breast and the breast skin just wasn't healthy enough to support the implant alone. The latissimus flap would wrap the implant and would act as a buffer between the radiated skin and the implant. These days, it's not used as much as it was. It's used more for sort of salvage procedures, women who aren't a candidate or don't want to have a DIEP flap or other free flap, and they want to stick with an implant reconstruction, but the skin is not healthy enough, usually from radiation. We will use the latissimus flap for that purpose. But I think the number of latissimus flaps being performed in 2023, 2024 are far less than, 2003 or even
That's
before.
that's what was offered to me, by the way, from a sick surgeon. And I do want to note that I was warned that I would not have good muscle movement afterwards. That could affect my muscles. So somebody who works out, I was concerned and I did not go forward with that. So
Yeah. I mean, there can be some shoulder issues after any breast surgery. Many patients with a latissimus flap make a full recovery, and there have actually been studies that have looked at strength and range of motion following a latissimus flap. And because there are a few other muscles that perform similar functions, they sort of compensate. And for your average person, your daily activities are usually unchanged, even with a latissimus flap.
That is good to know. And so I have here fat grafting.
Mhm,
Sounds
mhm.
interesting. Tell
Fat
us more.
grafting refers to movement of fat, and this is often something that patients get confused. So, deep flap in plastic surgery means we're moving tissue that has a blood supply. So, a deep flap is moving the abdominal skin and fat along with the deep inferior epigastric artery and vein. That's where DEEP comes from, DIEP. And we're moving that tissue along with the blood supply, reconnecting the blood supply. So that's a block of skin and fat that's moved. With fat grafting, graft means we're moving tissue without a blood supply. So just like a skin graft, a shave of skin is taken from the leg and maybe we put it on a burn on the hand. That skin graft needs to regrow a blood supply from wherever we put it on the hand. Fat grafting is the same thing. We're moving fat by harvesting it with liposuction, maybe from the thighs or the abdomen, and then we're injecting it into the breast to either add volume or treat contour deformities. And that graft needs to regrow a blood supply from the tissue in the breast. And so it's very important on how you fat graft. You can't overload the tissue. You need to inject small amounts into multiple layers to ensure that that graft has an opportunity to regrow a blood supply and stay a nice, soft, healthy fat graft, which is what we want.
So why wouldn't someone just go for that as opposed to a deep flap?
Because to reconstruct an entire breast with
Oh,
just fat grafting after a mastectomy, there's you have a little bit of fat under the skin, you have the chest muscle. You
yeah.
could inject fat into that, and people have done it, but it will take multiple rounds of fat grafting, multiple surgeries.
And I must tell you, I bet there's so many women that don't know this. So if they are not happy with their reconstruction from wherever they went, they can come in and have that conversation and say, and be empowered to say, how about fat grafting?
Yeah, sure, absolutely.
Getting
Yeah,
that
it's
out.
it's commonly used to improve reconstructions, make them more natural, improve little
It's
minor
wonderful.
imperfections.
I
So
love
it's a great
this.
tool.
Yeah, I think this is great. Aesthetic flat closure. Like, I didn't know what that meant until I took all of this efforts that I'm doing to social media. I've never heard the terminology. I was never just offered this. I didn't know it was a thing. So, can you
Sure,
tell us?
aesthetic flat closure. Yeah, it's often not discussed enough, and I think it should be because it is an option. You know, when I have a consultation with a patient who's going to undergo a mastectomy, I say there's three categories as far as options. You can have a natural tissue reconstruction, you can have an implant reconstruction, or you can have no reconstruction. You can have your mastectomy and the skin can be closed, or you can undergo an aesthetic flat closure. And the goal of an aesthetic flat closure is not to reconstruct the breast, but rather remove the excess skin, leave the patient with a nice, flat, clean chest wall that they're comfortable with. There's no extra skin or skin folds. If they want to wear a prosthesis, they can. But the goal is really just to leave them with a clean, neat chest wall contour.
This is very helpful. So, what about somebody that goes through, a double mastectomy 6 months later? They had an appointment with a plastic surgeon in their area because they're very, they're considering that. And they were only offered plastic surgery at their cancer center. And that's honestly what I think is going on. That's what happened to me. None of these advances are being talked about. In my opinion, I don't know what your thoughts are on that.
Well, I mean, I think that each location is different. Not everyone performs every operation. I think that most surgeons will focus on the operations that they perform and that they're comfortable with, and they may have a bias to them because they get good results doing a certain operation, and that's where their comfort level is. I think that all options should be discussed with the patient, even if it's something that you don't offer. You can certainly refer the patient out. But I think more and more patients are becoming more savvy. There are opportunities online, like through your organization, Learn, Look, Locate, and other sources online where patients can educate themselves on what the options were. And if they have a consultation with a surgeon and they hear, all I do is direct to implants and they want an aesthetic flat closure or they want a tug flap or a pap flap, then it behooves them to, go back to the surgeon, ask them what they think about it. Is there anyone in the area that performs it? And it never ever hurts. I'm never offended when a patient wants to have a second consultation. I think
Hmm.
that every patient needs to be comfortable with the decision that they're making. And if that's not with their original surgeon, then it may be someone else. And you just have to find a fit, find someone that you're comfortable, be happy with the options that you're hearing, and then move forward. And
Yeah,
if
I
that's not
think.
happening at the first option, don't be shy about seeking out another one.
And so to that, having this type of reconstruction, I'm curious what percentage of plastic surgeons are doing this incredible work, these advances? Is it pretty well
Yeah,
known, or is it
yeah. I mean, I think if you're in a more populated city, so if you're in New York, you're in Boston, Chicago, LA,
right?
you're Texas, in Austin. There's many surgeons in Dallas and Houston as well. If you're in places like that, there's a lot of microsurgeons that are performing these procedures. You'll be able to find it. In many other areas in the country, there aren't, and so I have a lot of patients that travel to see me. I've operated on women from Texas, Arizona, Florida,
Wow,
Ohio, this year, and a number of other states. And so where they were located, they
did
didn't
not.
have anyone that was offering what they wanted, and so they traveled for it. And the great thing that one of the few positive things that came out of COVID is we've become very good at communicating through telemedicine. And
Yes.
so that first visit to gather information, you don't even have to get on a plane. It can just be over Zoom or with whatever other program you're going to use.
And this is a microsurgeon. Is that correct?
Correct.
So someone should be
Correct.
looking for a microsurgeon. So let's talk about women who have not had reconstruction, but maybe consider it in a year or two, delayed reconstruction.
Sure. Yeah, absolutely. So immediate reconstruction, which is the way breast cancer reconstruction has really moved, is to do the immediate reconstruction refers to doing the reconstruction on the day of the mastectomy. For women who declined a mastectomy, I'm sorry, declined a reconstruction at the time of mastectomy, weren't offered one, or had a reconstruction that they're not happy with, their final reconstruction may happen a month later, a year later, 10 years later, and that's referred to as a delayed reconstruction. And so those options are open to patients, and sometimes patients are overwhelmed with. I actually just spoke to a woman before earlier this evening from Ohio. She was offered an implant reconstruction. Wasn't confident in the surgeon that she was talking to, was just stressed out about her diagnosis, opted to just say, you know what, I'm just going to do an aesthetic flat closure. And now, a year later, she's unhappy with that and now wants to discuss options. So, we're talking about options for a delayed reconstruction. And it still happens. And, it's important for women to know that you have options, seek them out, seek out that information, and then pick the option that you're most comfortable with.
Really helpful. So I think a topic that we've talked about before, Dr. Light, and then we have a page fully dedicated to this very important topic, breast implant illness. Touching upon the saline and silicone implants, as well as I call them the gummy bear implants, understanding the risks of this type of reconstruction.
Mhm.
I personally want to understand more about, the recall of the gummy bear implants because that was happening during my diagnosis, and kind of an update on what that was and what's going on now.
Sure. Yeah, so breast implant illness refers to a number of different symptoms. Common symptoms include rashes, hair loss, joint pain, muscle pain, dry eye, fatigue, brain fog, and the list is even more extensive. And it's women that have implants in. They can be saline implants, they can be silicone implants, and they begin to develop these symptoms. They usually seek out some sort of medical evaluation, and depending on what the symptoms, that may be with a neurologist, a dermatologist, a rheumatologist, they have a workup and nothing is found as a causative factor for the symptoms. Usually, whether it's sort of them realizing the symptoms started after they had the implants in, or by meeting other women that have experienced it, they diagnose themselves with breast implant illness and ultimately opt to have their implants removed. And there are many women out there that have, experienced relief from their symptoms after removing the implants. Not all women, but many women. And so, it's become an important, very important part of the discussion with breast implants, especially during the introductory phase, the consultation phase, when we're discussing risks and benefits. So much so that the FDA has now made it part of their patient decision checklist, which is a document that all patients should review and sign prior to having breast implants.
Wow. So it's really important that people understand this.
Yeah,
Yeah.
because I think that the in the breast implant illness community, there's a lot of disappointment and anger with the medical community because a lot of women didn't have a proper informed consent process.
Yes.
A lot of women, and I still have women coming into my office to this day, even from just having implants a few years ago, they were told that the silicone, they won't have a reaction to the silicone, that you can place the implants in and they'll last forever. You don't have to do any monitoring. It's sort of like a set it and forget it type of attitude, and that's really not true. There's, FDA recommendations if you have a silicone implant is to have an MRI 5 years after it goes in, and then every 2 years after that. And I see my patients every year to make sure my implant breast reconstructions to make sure if they have an implant in, they're not having any symptoms, and that they're not. There's no change in the exams, because if there's any change in their physical exam, we'll do imaging earlier. And so, when you don't inform patients of all of the possible issues with a procedure, um, especially with implants, if they develop those issues down the road, there's a sense of they weren't fully informed, and if they had known that, they would have made a different choice.
Sure.
And so, any of my patients who opt to undergo an implant reconstruction, I'm very, very thorough to make sure that they go through the patient decision checklist and we discuss all of these options ahead of time so they're fully aware of what to look for afterwards. Because for some women, an implant reconstruction is their only option. They're too thin to have a natural tissue
Yeah.
reconstruction, and they don't want an aesthetic flat closure. So they're really caught in a place where this is my only option. There's a number of issues that can happen with implants in the long term: capsular contracture, breast implant illness, and a number of other complications. And it's really critical for, as a plastic surgeon, for us to make sure that they're aware of these issues and look out for them.
For sure. This is so helpful. Anyone listening, please make sure you're aware of this because this was not really, this isn't discussed as much as I think it should be. One last question, the difference between breast reconstruction and breast augmentation.
Sure. Yeah. So for patients that you mean in terms of breast implant illness,
Yes.
yeah. So there's different options when patients have breast implant illness for breast augmentation versus breast reconstruction. And it really has to do with the fact that a breast augmentation patient still has their breast tissue. So the treatment for breast implant illness is to remove the implants and remove the capsule. And
Mm.
so my approach is to perform a complete total capsulectomy, done so that the implant is removed inside of the capsule. It's called an en bloc capsulectomy. And so that is the treatment for the breast implant illness. The capsule is sent to pathology and it's evaluated, but now the patient still has breast tissue behind. So a lot of times we'll do a lift or we'll do fat grafting in order to improve the shape of the breast and sort of get back to an aesthetic result that the patient's happy with. For breast reconstruction patients, because their breast tissue has already been removed, once we remove the implant and the capsule, the breast shape is lost. And so their options are really to transition to a natural tissue reconstruction like a DIEP flap.
Okay, okay. Very helpful. Dr. Light, this is a lot for a newly diagnosed person to process.
It is.
I am 5 years out and I still find this to be overwhelming of what is going on. In addition to these type of options, I do want to add that there's also medical and restorative tattooing to consider. And we have a
Correct.
fully dedicated page on that as well. And I think that is incredibly cool and unique. And, for a woman really looking to recreate and bring back all that might be lost in the fact that there's so many advances going on. So who's ever listening, I just want you to know, take a breath. This is a lot of information that Dr. Light just explained, and hopefully you take some time to really process, because these options are unique in every which way. You want to make sure you feel good with your surgeon, correct? Empowered,
Absolutely.
ask all questions, do your research, and Dr. Light, being a medical advisor for Learn Look Locate, is here to help guide you with any questions. So I'm just
Absolutely.
beyond grateful because we're bridging this gap that is just so needed. And just any closing thoughts? I just want to thank you so very much.
Yeah, I mean, I think that it is a lot of information for any patient who's newly diagnosed. And the best thing to do is, like you said, take a deep breath, figure out what you want, figure out what's important to you, make sure you understand what it's like to go through the procedures immediately. In other words, the what it's like to have the surgery, the immediate recovery, but then what's also involved down the line. What is
Yeah.
going to be your surveillance? What is going to be involved? What future surgeries may be required? And that'll really give you a better idea of what it's going to be like to live with your choices, to make sure that that's the right choice for you.
And I think as a survivor, one last thing I want to say is don't just take what your cancer center offers. There are other things, and there are other plastic surgeons outside of the cancer center that do a lot of advances. Not all of them do. Even some of the top ones in the country, I'm not sure offer all of this. So that's my last thought.
Yeah, yeah. I think I agree. If you're not hearing, what you want, never hurts to have a second opinion. You
Yeah.
have to advocate for yourself, and I think when you do, you'll be much happier with the end result.
Great. Thank you, Dr. Light. Thank you so
Uh,
much.
you're very welcome. Thank you.